Thanks, Viraj, for having me here. It's going to be really difficult, to prove our role. Like Dr. Aditi, she posted it right at the corner of her slide. There's a medical oncologist there, the tiny, tiny medical oncologist role. So probably before I actually did research on the topic, I also believed we had absolutely no role. But we have some role. We have a tiny role. So we'll just look at that role, what we do. So Dr. Shubhada ma'am has actually extensively covered this. So I'm just going to tell you the different entities because the treatment will be different depending on the entity. So we've got appendiceal mucinous neoplasms where you've got the low-grade appendiceal mucinous neoplasms and you've got the high-grade ones. Then you move on to appendiceal adenocarcinomas where you have the signet ring and you have the mucinous adenocarcinomas and you have the carcinoma undifferentiated type. Then you move on to the goblet cell, which ma'am has very beautifully described. There's a stringent criteria of how you actually define appendiceal goblet cell adenocarcinomas. Then you've got the NET, the neuroendocrine neoplasms, where you've got the neuroendocrine tumors and you've got the neuroendocrine carcinomas. So we are going to go through the treatment topic to topic. So this has already been told by ma'am. What I really want to focus on is the lymph node involvement. In a low-grade man, the lymph node involvement is rare. The high-grade has also it's actually rare. In the mucinous adenocarcinoma, grade 2 has about 17% lymph node involvement. Grade 3 is poorly differentiated with signet rings. Almost 72% have a lymph node involvement. So obviously, our treatment will depend on the lymph node involvement because finally it is one of the prognostic factors for the outcome. So moving on. So the talk would go on with how do we treat different entities, and then I'll give you the evidence based on histology, and then I will ultimately give you the role of each and every kind of therapy that we use. So for man, low-grade man and low-grade PMP, we don't have any role. The surgeons play a maximum role here. Grade 2, grade 3 man and PMP, pre-op, post-op 5FU based chemotherapy is very similar to CRC. Pre-op chemotherapy has improved clinical histological responses in almost 29% of the population, and this is a study by Bijalik et al. I will show you the evidence later on. Unresectable disease, we have that tiny role. Systemic chemotherapy can provide disease control in almost 50% of the case, and I have the Shapiro's trial further on. So this also has been shown by Dr. Shubhada ma'am very nicely. She has described. So there is a slight change in the classification, which she has already said. So how do we treat when we have neuroendocrine? So adjuvant setting, we don't have a role. Neuroendocrine carcinoma, adjuvant post-resection of NEC, we have a role. Locally advanced metastatic, definitely you can consider for NACT. Now, what are the regimens that we use? We use cis-ITO, we use carbo-ITO, we use a combination of leucovorin 5FU oxaliplatin, leucovorin 5FU irinotecan, capecitabine plus minus temozolomide. So these are some of the regimens that we use. So you have the evidence from the PROMIT study where you have octreotide LAR versus placebo, octreotide showing improvement in the time to treatment progression of about 14.3 months versus 6 months. However, there were no OS benefits because of crossover in this trial. Then you have evidence from the RADIANT-2, which also said that we have some role in systemic therapy, that is everolimus, improving the PFS in advanced NETs and carcinoid syndromes versus octreotide alone, 16 months versus 11 months. And of course, you have the RADIANT-4, similar to the RADIANT-2 trial. So similar curves, these are just the same thing. You have octreotide doing better than placebo in terms of PFS and overall survival in the PROMIT trial, and that is the RADIANT-2. The blue curve, you see there is an improvement with everolimus versus placebo. Now coming to goblet cell adenocarcinoma, now this is another entity. Now this is more aggressive than the typical NETs. Now you have more frequent transmural invasions, you have more frequent lymph node involvement and peritoneal metastasis. This has already been told to you in the previous talks. So they are treated generally like adenocarcinomas. So they, again, you grade them as grade 1, grade 2, grade 3, and they tend to be a little different from adenocarcinomas because they have about 10% of KRAS involvement. So do we have a role of systemic therapy here? Adjuvant chemotherapy is recommended in stage 3 and stage 4 disease. 5-FU based chemotherapy is recommended, though we don't actually have RCT data to exist for this. Retrospective studies have actually shown, have failed to show any sort of survival benefit, and it's likely because there is selection bias in the studies, and also because of small numbers. So most of the studies in appendiceal neoplasms don't actually categorize them into different entities like we've seen, like I've showed you. So most of the time it's a pooling of all the data. And despite of all of this, the recent report from the National Cancer Database has suggested that there is an improvement in the overall survival in a node-positive disease patients who receive adjuvant chemotherapy. So this is where we come here. Goblet cell, we have a role. And now next is the colonic type and the signet adenocarcinoma. How are they different from, how are they different from the remaining entities? They tend to have a high TNB, I mean few percentage of them, and high MSI. So we know that whenever there's a high MSI and a high TNB, there's a small role of immunotherapy. Signet ring cells tend to be very aggressive. The lymph node involvement tends to be very high, and obviously this is a predictor of survival. So if you have a standard appendiceal adenocarcinoma, you have presentation at T3, T4 at 63%. It is 91% in signet ring tumors. N1 disease is almost 61% in a signet ring cell disease. Metastatic disease is about 56%, and the median survival is just 24 months in a signet ring versus standard, it is about 48 months. So where does the role of systemic therapy come here? If you have peritoneal metastasis, retrospective data does suggest that along with CRS and HIPEC, which the surgeons do, we do have improvement in survivals if you add on systemic therapy versus only systemic therapy alone. DFS is about 23 months and overall survival of about 48 months. Systemic chemotherapy is recommended in appendiceal adenocarcinomas, but there are no specific guidelines. So what we use is the colorectal guidelines. And but again, we have a role here. So if you have a non-metastatic appendiceal adenocarcinoma without lymph node involvement, do not offer systemic therapy. If you have a completely resected, localized tumor with lymph node involvement, probably will benefit from a doublet chemotherapy. That is the 5-FU and oxaliplatin doublet. If you have a metastatic disease, you should receive systemic therapies that were used in metastatic colorectal disease. And peri-op regimens can be offered in patients who you feel are going to be a surgical candidate. Now I have evidence for this. Now we finally come to the evidence for all that I have actually told you. So this is a study. It's by Wang et al. And it's actually looking at the SEER-based data of how you divide your treatment based on histology. So this is a histology-driven treatment for different kinds of appendiceal carcinoma and appendiceal neoplasms. So here the data was actually of about 8,733 patients. This was taken from 1998 onwards all the way to 2016. Now actually when you look at the SEER data, there has been a shift in how patients have actually had their survival. So earlier on, chemotherapy did not actually improve either cancer-specific survivals or overall survivals. But there has been a trend, or there's a shift. From 2012 onwards, whatever data that has been looked into, there is definitely an improvement in the cancer-specific survivals. There are also improvements in the overall survivals. But not everybody gets this benefit. So who are these people who actually get it? It is the people who have a mucinous adenocarcinoma, non-mucinous adenocarcinoma, and the signet ring. These are the people who will actually benefit from from chemotherapy. It is not, according to this data, it is not the mixed NEN type, the goblet, or the NETs or the NEC. So these are probably not the people that you would offer. Here again, in this study, they said they looked into lymph nodes being a very important marker of survival. So this, you can actually see this, the hazard ratio. Now people who did not receive chemotherapy versus people who received chemotherapy, the hazard ratio of about 0.72, which was statistically significant. This is vis-a-vis the data that was there earlier on, where we didn't actually have better cancer survivals or overall survivals with chemotherapy. So now there is a shift, and we do have some role. This, you can see the pathologies, like I said, mucinous, non-mucinous, and SRC, the signet ring. These are the people that you would offer, but GCC and MNEC, you can actually see that it is worse. The survival is worse if you offer chemotherapy. Now, timing of chemotherapy is very important. Yes, we have established that we have a small role, but when do we give it? Do we give it pre-op? Do we give it peri-op? Do we give it post-op? How do we decide? So this is a study, again a big study, which was done by to look at the role of chemotherapy and when do we actually time it. And here the authors actually do recognize that it is only the high-grade ones that actually require chemotherapy, and it's very difficult to decide what is the right time to give chemotherapy. So this looked into nearly 55 articles, 55 studies were included in this analysis, and they had nearly 33 on HIPEC, and they had 42 articles on systemic chemotherapy. So it was a very big study. I also brought this study to show you the different regimens that have been used. Most popular regimen, almost 18 trials looked into 5-FU and capecitabine as their regimen. 5-FU oxaliplatin is again equally a very common regimen that we all use. Bevacizumab, 15 articles actually had bevacizumab usage, and of course rest of them have been used in a minor role. This study actually said that there is a role of chemotherapy. There is a slight improvement in the overall survival, and if you actually provide chemotherapy in the right setting. Now the rationale for chemotherapy, giving chemotherapy, there are so many things. Like we already know, we give pre-op chemotherapy when we want to know the biology of the disease. We want to actually study how this disease is actually going to move on forward. Can we downstage the tumor? Can we, probably there's a delay in doing the surgery, so we want to buy time and then we give chemotherapy. So that's some of the rationales for giving pre-op chemotherapy. Post-operative chemotherapy, sometimes we offer it to provide and avoid unnecessary delays in progression. We prefer to give it post-operative to avoid translational research, collection of tissue. For research purposes, if you don't want to actually damage the tissue with the pre-operative chemotherapy, then that is one of the rationale to give post-op chemotherapy. So finally, but the role of perioperative chemotherapy is not very conclusive, and most of the trials have a mixed population, so we don't really have a very good role for perioperative chemotherapy. Some of the problems is because there is a selection bias. There is a lot of well-differentiated population, so they are actually chemo-resistant. So when you have trials which have a chemo-resistant population, a population that actually should not be given chemotherapy, you're not actually going to get a benefit. Also, a lot of studies did not mention the percentage of signatoring cells. So it is the ones who are aggressive which will actually benefit from the chemotherapy. And a lot of times we don't know what is the duration of perioperative chemotherapy. So this is another study which Dr. Aditi, ma'am, this is actually saying that we have some role after you. It's like you were rightly saying, you can do a good HIPEC, but if you don't have a good chemotherapy after that, you're actually going to lose that benefit. So this is one of the studies that actually said a post-op chemotherapy to be given to actually improve the PFS in high-grade appendiceal malignancies post HIPEC or cytoreductive surgeries. So this is, the blue curve is just, this is in the low grade. So in the low grade, there is no benefit. So the blue curve is HIPEC alone, which is actually better than HIPEC plus systemic chemotherapy. And you can also see overall survival, HIPEC was better. But when you come to the high grade, this is where we have a role. So high grade, you can see the one which is the red curve. That is the HIPEC along with adjuvant systemic chemotherapy. It's actually better in terms of PFS. It's actually better in terms of OS. Now, that is for post-op chemotherapy. But what about pre-op chemotherapy? Because a lot of times you want to give pre-op chemotherapy. Now, you can look at the green curve. So you can see that there is a worse survival. If you give chemotherapy first and then do HIPEC, you can actually shorten the survival of the patient, both in terms of PFS and OS. So probably this is a subgroup where you can give chemotherapy, but it has to be a post-op chemotherapy, and there is no role for pre-op chemotherapy. Now, what about pre-op and post-op? Let's be medical oncologists, let's be more greedy. Let's give a lot of chemotherapy. So that is the blue curve, the light blue curve. It's actually reducing the survival. So there's no role of pre-op. You can do post-op, but again, it is not in the low grade, it is in the high grade disease.
But this is MAN, not adenocarcinoma.
This is MAN, yes. Now we look at the role of oxaliplatin-based chemotherapies. This is, this is probably the first trial that established the good role of oxaliplatin. So this study actually said that FOLFOX4 is a decent regimen to be used. It improves the progression-free survival. It improves the overall survival. And this is probably something that you can give safely to your population, though this study did not demarcate their populations based on KRAS. Or, they didn't have much of segregation. based on the RAS status. But this study established the role of safe usage of FOLFOX4. So this is one of the regimens that we commonly use as medical oncologists. This is actually the famous Shapiro Trial, where they looked at systemic chemotherapy having a role in patients who were suboptimal candidates for cytoreductive surgery. And in this, probably there is a role of giving systemic chemotherapy. I'll show you. There is improvement in both in terms of, I'll take 2 more minutes. Progression-free survival, overall survival, and this, again, most of the patients were on FOLFOX4-based regimens. That's what we normally use as medical oncologists as well. So role of anti-VEGF, so I'm just going to take 2 more minutes, role of anti-VEGF and EGFR. So I know this has come out as a busy slide, but what I was trying to show you in this slide is that in here, a lot of patients actually received, you can see, FOLFOX plus BEV regimen. Most of the patients received it. But in this particular study, they said that there was actually no benefit of giving bevacizumab. And in fact, it was worse off in the survivals. This was actually a very big study by Tejani et al. Again, there's something wrong with this slide. So you can see that, bevacizumab actually worsened the survival. So this study said there is no role of Bev, but there's another study that actually supported. This was again a big study by Chloe et al, Cho et al, which said that there is a role of bevacizumab. You need to choose your population well, and in fact, the people who are VEGFR positive are actually the patients who are going to have a worse survival. So. Here you can see that, people, this is a PFS curve. You can see the people who received BEV, that is the yellow curve, actually did better in terms of survival as vis-a-vis those who did not receive. But the argument that the authors gave was, it was not the BEV that brought the effect. It was actually the chemotherapy backbone, which was quite an, intensive and multi-drug regimen, where actually brought the survival benefit. So again, this is a plus-minus role, but nonetheless, this was a positive trial. So, So the role of anti-EGFR. So I'm going to talk about, can you move the next slide? Yeah, it's okay, yeah. So it's the same study. I just want to show you the panitumumab and cetuximab data. There's actually no good data for it. It's small population, but it actually worsened the survival. So there isn't a positive data on cetuximab or panitumumab, but there is some role for bevacizumab. This is another trial, COMBACT trial, which is again a big trial. This trial supported the use of cetuximab, but again, if you look at cetuximab data, you'll get a very divided opinion. Some people support it, some people do not support it, but most of the times you see trials that do not support its role. But nonetheless, we do use it in our population. Is there any role of immunotherapy? These are cold tumors. It's you'll hardly find 1 to 2% of your population that is high TNB positive. So probably no. So to conclude, pre-op chemotherapy, worse survival, so do not offer it. Minimal role of perioperative systemic chemotherapy in addition to CRS and high PEC. This is for the low-grade mucinous peritoneal disease. You should use systemic therapy only in clinical trials. You shouldn't use it in your practice. Perioperative chemotherapy, again, it's plus minus. So you only offer it to patients if you feel it will provide an additional benefit to a good HIPEC that has been done by your surgeon. Post-operative chemotherapy definitely has a role in high-grade disease, signet ring, and lymph node involvement. Probably this is the population. Unresectable disease, that's where we have a role. But you need to, how do you select your patient? How do you select your chemotherapy? That role has not been established yet. Anti-angiogenic agents, there are no studies to actually have a strong evidence for the benefit, but unresectable settings, it does seem to have some sort of evidence. We need to have further studies to look at what is the role of maintenance chemotherapy, how do we intermittently dose it, and how do you tailor your treatment based on histology. Thank you.